We are live. Hello, Dr. Carys Sonnenberg, and mega congratulations on this book, Women's Health Made Easy, which is incredible. You are a co-author of it with the incredible Angela Wright and Angela Sharma, who are also equally brilliant. Tell me, what made the three of you put your heads together and do this, and who is it primarily aimed at?
So first of all, thank you so much for having me. And yes, so we got the opportunity from the Primary Care Women's Health Society, and we said yes. And the three of us together had a role of producing a book, which was originally supposed to be 50,000 words, and they wanted a pro forma of what they thought would be in it. It was for people to help. It was for primary care, essentially. So aimed at health professionals of all kinds. So medical students, GPs, secondary care doctors, pharmacists, nurses, physicians associates, and also educated women who want to have more knowledge about what types of options might be available for their care, and we wanted to make it really user friendly. So they asked us to write the pro forma, so we did that, and it was sent off for approval. And then we started writing and realized that 50,000 words was by no means anywhere near enough. So we spoke to the publisher, who was very happy after some negotiation for us to extend a little bit. So that's what we did. So we wanted it to be the building blocks for care. So starting from the beginning, the anatomy and physiology chapter was something that was really important for me to put in, reminding people how the ovary works, reminding people what the hormones are, what the body actually is, where the vulva is, what the difference is between the vulva, vagina, the cervix, and obviously the uterus and the ovaries. And then we wanted to talk about the different hormonal stages of life, like puberty, perimenopause, and menopause. And then we go on to birth control, contraception, period problems. We have breast, we have menopause, HRT, sexual problems, vaginal problems, cancer, safeguarding. There's a huge amount in it that we thought would be really helpful, but there's also things in it. It's not just lists of symptoms. We wanted to make it, we have got sort of almost 60 years of general practice between us, which is ridiculous, isn't it? So we had all of that information that we thought, goodness, we weren't trained in this. We didn't know this when we started off. How can we make it? We felt that we had such a special and amazing opportunity to write something that was going to help support others care for women better. And it just became this like life all-encompassing event, as I'm sure you remember.
No, I remember you saying, I got them buried under my book. It's like, I know how you feel.
I can't carry on. Yeah, it was just so much. But it keeps you awake day and night when you've got something like this, doesn't it? You think it's always on your mind, and you're walking on a dog walk thinking, oh, have I put that in? And did I mention this? And is this clear? And how can I say that better? And how can I do it in the limitation of words? And it we were so passionate about it, and we set the chapters, so we divided them up, so we each had them, and they were just so perfect for each of us. It was just unbelievably good the way it worked out. We had our interests and things, and then we set at it, and then we wrote it, and you're back and forth, of course, with the publisher, getting it corrected. You think you've done it wonderfully, and he's like, no, go through with this red pen, no, and it's like, oh, okay, I see what you're looking at. We put case studies in and questions for contraception, and it was just such a wonderful learning opportunity for me. So I look back on it now and think, I wish the younger me had known this, because I feel so much more knowledgeable now and able to help and support others. And during the way, people helped reading it, going, Carys, why have you written this? This doesn't sound right. Where did you get this from? And then I gave it to other people to read as well, and go, Diane read it and was going, there's not enough in surgical menopause in here, and I go, oh yeah, because you're writing, and sometimes you overlook things without really realizing. So people helped to proofread it, gave their opinions, and then we had to proofread each other's chapters. So there was so much backing and forthing, but I'm so happy with it. I just feel genuinely immensely pleased that it's out there. And we've had some lovely feedback from people who found it really helpful, in their clinical care, and from women who found it really helpful. So, and that's all we wanted, was to just have it out there, and we can keep updating it, and it will be a resource that's available for as long as it can be.
Yes, exactly. And it is really, I mean, because with 3 writers as well, you'd expect every section, not that I've gone through all of them yet, but you'd expect every section to sort of sound slightly different, but actually they don't. It seamlessly flows. It's not sort of like, oh, that was a change in tone. So it's very, very, very seamless in that respect, which is good. But it's also just, I mean, I don't know whether or not people can see here, but it's just, it is so point form, if you know what I'm saying. So basically, it's so easy and clear then. You don't feel like you're reading bucket loads of text and having to absorb it. It's all short, simple sentences that are very clear, and that makes it so much easier as a reference book. You don't feel overwhelmed.
No, it wasn't. They set it, the publisher did a beautiful job of setting it out, and they obviously had something in mind. They've got other books of this type of thing, like Contraception Made Easy, Lab Tests Made Easy, Dermatology Made Easy. So we had to write it in line with how they had set theirs out previously. And then they made it colourful, which made it really easy to see. They set the tables out beautifully. So actually they've done a wonderful job of making what we provided, the information we provided to them in Word documents, it really great. Yeah, so it was just they obviously had in mind what they wanted, and it just, we were able to help by just providing the content.
Yeah, and it's plain English too, which is good as well. It's not sort of, there's no sort of interleukin 3s and 6s and things like where people go, oh, I don't know what that means. You've got to spend half an hour going away and looking it up. It's actually, really, even for people like me, it's a very gentle read.
You could, I mean, you are really educated. I think you would gain a lot from reading different parts of it that maybe you just didn't realize before. The thing is, when I read Angela's chapters, I'm like, oh, that's really helpful. So I had to do a talk on gynecological cancers, and so I was able to look at everything Angela had written, thought, wonderful, this is all here. I can just supplement with a couple of little bits just to extend the talk, and it's really easy to understand where it is. And that's what we wanted. We wanted something that was super easy for people just to look at, even for 5 minutes, and think, oh, I didn't know that. And then we have links in there so people can read more, because there's such a vast amount of information out there. And if you start to go down the really detail of explaining things, then it just becomes quite complicated. But we did want to make sure there were enough words so that things were explained and not oversimplified, so that you just don't come out with those building blocks you need at the beginning to try and understand how the body works. So yes, it was really good. And particularly for me, the menopause and the HRT chapters were just so important to put in. We were going to have menopause and HRT in one chapter, but it was just such a vastly undertaught area, as you know. So we separated them and gave them a chapter each, which meant we could expand all the different types of, menopause, perimenopause, holistic care, POI, early menopause, surgical menopause, medical menopause, menopause after cancer after menopause. And then we wanted to go into HRT in detail, all the different products, how you prescribe it. Because I'd have my medical students come in going, how do you choose an estrogen? And what do you do then? What else do you give? Why do you give that? And so we wanted to try and make it as easy as possible to show people what the options were. But obviously they've got trusted websites to look at as well. So and then during the writing of it, of course, there were about 100 massive consensus statement updates. So we had to go and update it multiple times. But that was good. It really makes you learn and understand. And there were so many helpful people. I mean, I just simply can't believe how wonderful people were with taking time to proofread and giving opinion and questions, thinking even simply things like, well, how long should a period be? And I'd be thinking, well, I mean, that can't be difficult to find. So, but then I'd ask people, no, that's wrong. That's too short. That if you have a period over 21 days, that's not correct. But this is what the ESHRA guidance says. So why isn't it correct? Well, no, and I just don't think that's right. So there's so much different opinion to try and even consider. So we managed to get through everything and learn a lot and support each other. And Angela and Andrew are absolutely just delights. They're just incredible sources of support and knowledge and sense. And yeah, it was wonderful. They were just wonderful to write with.
Yeah, yes, I can imagine. Let us get into some of the nitty gritty, shall we? Because some of your chapters that I've got, you did contraception, the HRT ones, or menopause and the HRT ones, and the breasts. So
and breasts and anatomy and physiology. So the first chapter was the one about the vulva, female anatomy and physiology. Yeah.
Good. Well, I'm not going to talk about that one. because I'm going to get stuck right into the other things. Contraception, because these are things that are really confusing for a lot of people. And we've got a lot of talk at the moment around the sort of safety of the pill and those sorts of things. So when you were putting this together, how did you think, okay, I'm going to address this, and how important is it for GPs and healthcare professionals when they're talking to people about contraception to understand the risks and the benefits and explain them really well?
Oh, it's just vital. I run a long-acting contraception clinic once a week. I've done it for years now, and giving people the right information about birth control, which is a term that is commonly used now, is so important. We had a wonderful talk at the Primary Care Women's Health Society conference from Dr. Fran Yarlett about hormone hesitancy. She talked about things which people are posting on social media that are making people very frightened to use hormones which they deem to be synthetic. And is this the right thing to be putting into your body? And there's obviously such a lot of opinion on this. So I think we can look at this in two different ways. It's important to that we have such wonderful ways of protecting ourselves from becoming pregnant if we don't want to. So we're planning our pregnancy. The risk of pregnancy for some people is high. So we want to be able to provide people with a range of effective birth control methods. And we also want to be able to talk through the pros and cons. So there are some absolutely fabulous websites that I send to patients so they can read in advance all the differences between the different methods of contraception. So we want to know, how effective is it? How do I take it? What's going to happen to my bleeding pattern? When will my fertility return to normal? What side effects might I get? And we also want to know if I have another condition, like I want contraception, but I've got really bad acne, or I've got terrible premenstrual syndrome, or I'm in perimenopause, my hormones are, really fluctuating, and I don't want to become pregnant. So we need to think that birth control can also be used to treat medical conditions, endometriosis, adenomyosis, use of the Mirena coil particularly, can be used for contraception, management of heavy bleeding. 20 to 30% of women experience heavy bleeding, flooding, clots bigger than a centimetre, doubling up on sanitary pads, getting up at night, flooding through their clothes. That becomes their iron becomes low. They develop iron deficiency anemia. We also have people with PCOS who don't have periods regularly. So we need to protect the lining of their womb from endometrial cancer. So either bringing on a period every 3 months using a progestogen, or giving them a hormonal method of contraception, which can also help with other symptoms as well. People with PMS and PMDD, these can be life-saving types of things for them. So it's really important to understand which hormone you're using, synthetic, so ethinyl estradiol, you're using an estradiol, you're using an estetral pill, so lots of different types of estrogen, or you're giving different types of progestogen, and knowing what they are, knowing how they work, which generation of progestogen you're looking at, and which receptors they work at, why side effects might happen, what to do if there's bleeding. It's just it's an enormous topic. It just couldn't be. It takes a long time to understand how the pills work and what different types of pills there are, particularly as short-acting methods, and you've got your long-acting effective methods, more effective methods. So it's such an enormous topic, and to get it right, I am just so passionate about it, because you can change someone's life by giving them a hormone. You can make them feel really well or really unwell. So you need to talk to them about the possible side effects with mood, risk of breast cancer, for example. There are risks with taking things into your body, but there are also risks with not taking them. So becoming pregnant, having a baby when you don't want to, having to have a termination or something like that. Huge risks to the woman. So we have to give people choice and not frighten them, but we need to show them these are the choices that might be really helpful. What do you think would be work best for you? And if this doesn't work for you, then we have loads of other things that might work. So in talking honestly, the amount of people who've said to me, "Oh, never, ever having an IUD, ever." And I might say, okay.
I always said that.
I totally understand what you're thinking. Yeah, but actually sometimes when they hold it in their hand and you talk through sensibly, they go, oh, well, I thought it was this. And actually now from what you're saying and I'm seeing, it isn't what I've been frightened about. So maybe that would work for me. And it doesn't work for everyone, but it does work beautifully for some people. Our bodies
There's an ad somewhere that I saw on social media with somebody holding up an IUD that was, literally, the size of me virtually. And it was sort of like, no, that really is going to scare somebody because it's a tiny little thing.
really small, and it is, yeah. So of course there are huge opinions that are about all different sorts of things, but people shouldn't be frightened to make choices that are right for them, and I think and getting the right information from good websites, from us as people who are passionate about educating is just really good for women to know that, because we don't know
choices. You mentioned there as well about pregnancy, and we have seen in the UK a rise in abortion rates from around about 214,000 in 2021 to about 277,000 in 2023, and at the same time a corresponding rise in popularity of natural methods of contraception. And in the book, I think you say there's an 85% failure rate. So this is another thing that really has to be explained to people, because there's, as you say, pregnancy and abortions can have an effect on women in many ways. So how do you get that across in the book as something that should be discussed as well with patients?
So many people will want to consider all the options, and they might not want to take a hormone. But they might want to consider, for example, a copper coil, which doesn't have any hormones. So that's becoming more popular now, certainly, but bleeding can be a little bit heavier and longer with that. They might want to consider natural fertility methods. So you're looking, if they've got a very regular cycle, it could be something they want to consider. But it's if your cycle is irregular or you're in perimenopause, it's not something you can rely on. You can look at barrier methods, but they are only effective if you use them completely correctly. And those might be something to consider. But the withdrawal method is something that many people use, but that's got a very high failure rate. So I think it's educating people about, well, this is how effective this is if it's taken completely correctly. This is how effective it might be in the real world when, we accidentally miss it, or we have diarrhea or vomiting, or we're late with a pill, for example, or we might forget to replace our implant or coil. There is some maybe some reduction, of course, in effectiveness if it's not being taken correctly. So I think people really need to understand, how effective they are. So there's a doctor called Anne Connolly, who has just been inspirational to me, and her question always to ask women was, how not pregnant do you want to be? So if you don't think pregnant, becoming pregnant would not be suitable at all for you, then you want to be taking a very effective method of contraception. But if becoming pregnant would be something that would be acceptable to you at this time, then using a method of contraception that might not be quite as effective might be something you want to consider. You've got to sort of say that to the women. Look, these are the effectiveness, and this is, and you need to take it work, not taking medication that could interact, like medication, for example. So there is used to, the pill check for me when I was a young doctor, I used to think, oh, lovely. Now it's like, oh, right, a massive amount to discuss in this consultation. So I need to make sure there's no, problems prescribing. It's safe, it's effective. The side effects, that that you understand how to take it correctly, when to come back. There's a lot.
Yeah, there is a lot there. Sorry, my dog was barking over that. But I think in the end which was cutting your audio out a little bit, but you're saying basically you have to make sure that it's safe and effective and matches what the person wants.
Yeah.
All right. With contraception, then we get to this sort of grey area where we're between perimenopause and menopause, and we still might need contraception, but we also want to have a bit of HRT. How do you cover that in the book?
So perimenopause is a really interesting time. So of course, women still need contraception. So you can stop using a contraceptive method if your period stops, your natural period, last menstrual period is under the age of 50, you need 2 more years of contraception. If your last menstrual period is above the age of 50, you need another year. And we can all, as people with female bodies, can stop using contraception at the age of 55. Even if you're having cycles, then at that point, it's thought that it is so unlikely for you to become pregnant. So we can use contraceptive methods as part of hormone replacement therapy. One commonly used one is the hormonal IUD, the Mirena type 52 milligram levonorgestrel IUD, can be used for up to 5 years. We can use some progestogen only methods alongside HRT, or we can use some off license as the progestogen part of HRT, which is really good in perimenopause, because often people have this horrible, like cyclical, or not cyclical, really fluctuating mood hormone change, and we can suppress ovarian function using some of the progestogen only methods, which can be so helpful for perimenopause. Something like drospirenone or desogestrel, 150 micrograms off license, these can be used and be so useful for people in perimenopause. So they then have that, it can make things a little bit easier and provide contraception, and you can add estrogen in as a hormone replacement therapy in order to help them at that stage. And that can also be very helpful for premenstrual syndrome. I've got lots of people who really like the use of that. Of course, that is off license, and not everyone can prescribe or is willing to prescribe off license, but it is recommended by the British Menopause Society as one of their progestogen choices.
Yeah. When it comes to a point where you think, okay, I'm now approaching 50, 51. Is it time for me to, am I menopausal because the pill might be masking my symptoms? But when or how do you know when to swap somebody then from a regime that gives them a bleed to one that doesn't?
So if you are above the age of 55 and you have been taking cyclical sequential HRT for a maximum of 5 years, we would then switch you to continuous combined HRT, so a daily estrogen and a daily progestogen, and that would be within 5 years or the age of 54, whichever comes first. And that is because we know the continuous combined regimes of HRT give a little bit better protection for the endometrium, the lining of the womb. We want to protect that from changes like endometrial cancer. So we usually change people onto a no bleed preparation. But if we're starting somebody who's been on a progestogen only method of contraception for years, they haven't had a bleed for years, we can give them a continuous combined regime as long as they've had no bleed for more than a year, same as someone who's had an ablation. So you sort of look at their medical history, what their bleeding pattern is when you're starting them, and then you can choose whether you give them sequential HRT or continuous combined HRT. Because often people, if they've had no bleeds on a progestogen only method for years, they're not going to be grateful to you for bringing their monthly bleed back. So there are ways of doing it. You just have to look at it as an individual approach.
Yeah. The menopause symptoms. Now, this was the one that I didn't know this myself. I did not know this myself, actually, that in some people, vasomotor symptoms can last 3 to 4 hours. That would be a living hell, especially if it were happening overnight or in the middle of a big meeting. I mean, I know I look like I'm having a continuous one right now, but it is something like 35 degrees here, so I'm melting in front of you. But that is a hell of a long time to be having a vasomotor symptom, isn't it? Or having a hot sweat.
Definitely. And I think often people describe that they feel hot, they wake up and they're not having that like sweat that comes up, which would last, 30 minutes to half an hour or something. Sometimes they can go on for a lot longer, but yeah, 3 hours, that's a huge time, isn't it?
Yeah, it really is. I'm surprised about that. Yeah. In terms of them, you go through the treatment options that are available, and there are sort of very many of them. And again, it's a matter of informed consent. So how important? What are if you're a doctor and somebody's coming into you and saying, I want to start HRT, what are the main sort of checkpoints that you talk about in the book that they should run through to cover?
So you want to be looking at listening for start, so listening to their symptoms. You want to be looking at their past medical history, their family history, medications that they might be taking, and supplements certainly that they might be taking, any allergies, and you want to be looking at their lifestyle. I often say to my patients now in GP, right, but 1 minute, I want to understand how you're living your life. So these are your lifestyle pillars. Can you just quickly tell me what's going on with you in this sort of thing? It gives you such a good insight into how they're getting on. I mean, I'd love to spend 10 minutes with them listening, but actually I need that information. So you want to be looking at their risk factors, their blood pressure, their BMI. You're looking for risk and for prescribing. So you want to think, is this person, are there any contraindications to giving hormones? Are there any cautions to giving hormones? Should I not give an oral tablet, for example, in this person? Could I give an oral tablet? And is there anything that I need to worry about? Abnormal liver function tests or irregular bleeding that hasn't been investigated, history of estrogen-independent tumour, skin conditions that are severe. You want to be thinking, is this person in the middle of a massive heart attack or an active thromboembolic event? So if there are no contraindications, and of course we both know there are very few contraindications, you need to then say to the woman, right, so it's really, there's a lot to read. I want you to just think about whether you'd like to use the hormones. These are the most effective treatment. The benefits for you might be blah, 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 depending on whether she's POI or early menopause or menopause, a woman who's having menopause over the age of 45. And the risks are, and then these other options are talking therapies, non-hormonal treatments. And then we're looking at fezolinetant now on their NICE guidance. And we're looking also, you might want to be considering alternative and complementary therapies. And if you were, there is very little evidence, but I would suggest that you see somebody for advice about this because of the risk of taking something that could interact with your medical conditions or your medication. And particularly,
let me knock those ones off straight away here, because I was going to ask you about this as well. But there are certain ones that are quite popular. That I think there's black cohosh and the isoflavones, the phytoestrogens. Sorry, the phytoestrogens and the what is the other one? Black cohosh. Oh, St. John's wort. So if people have got certain conditions or are taking certain herbal remedies, what should they be watching out for those ones in particular?
Well, so black cohosh, if you're getting it, you need to know that it could affect liver function, and it could interact with medication. Same with St. John's wort. You shouldn't take that alongside any hormone treatment, particularly contraception or hormone replacement therapy. And the middle one you said has gone out of my mind.
Phytoestrogens.
Phytoestrogens. Okay. So yes, I mean, those are usually safe in the diet for everybody, but we wouldn't be recommending somebody with a history of breast cancer or an estrogen-dependent tumor take a supplement of those. And that's what it's. And interestingly, I had a patient who called up and said, "Oh, would you mind checking whether any of my supplements could interact with my thyroxine?"
That's very, 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 very good of them.
Very good of them. So I said, oh, just how many supplements are you on, just of interest? Because, sometimes people are on a multitude. So so she explained what she was taking, and it turns out, ashwagandha can affect that, so can magnesium. So people often take medications. They don't know what's in the bottle. So we are all the same. I mean, if you were to ask me what's in my multivitamin, I'd be like, I don't know what dose of that's in it, but I think it's fine. But I mean, I think it is fine. But if I could quite easily be on 2 or 3 multivitamins. Maybe there's doses similar in each one. So super dosing is a big thing. We don't need to be doing that. It can cause harm. So I think it's really important. Food first approach, supplementing vitamin D. I mean, it says in the winter months, but we do want to be we want to be keeping a good healthy level of vitamin D. But iron is the thing for me. So iron, lots and lots of women have got a low ferritin level. They may not be iron deficiency anemia or have iron deficiency anemia, but they have a low ferritin level. And we need a good healthy ferritin level, 50 to 70 or above, particularly for hair growth. So, and if you've got iron deficiency, you're having heavy flooding periods in perimenopause, and you've got an iron of 13, so really quite low, it takes months to build that up using oral iron therapy, months and months and months. And many people have given up by the time they get to a level which actually could be slightly high enough for them. And they often don't take it correctly. So they might not take it on an empty stomach. They might take it with tea, coffee, eggs, dairy, and they shouldn't. So it's really important to get advice on those things. So things like zinc in your diet, magnesium in your diet, making sure you're having enough protein, fiber, lots of fruits and vegetables, giving yourself a chance to absorb, making sure your B vitamins are adequate. Particularly, these are all really important. A holistic approach is important. I put a part in the chapter of the book about how to manage this holistic approach. Somebody said, oh, you don't need to put supplements in there. And I said, well, lots of women are using these. So we do actually really need to be aware of them. And there are some really useful websites that help us look at interaction between drugs and supplements that people might be taking, which is really, we have to know this now. We were not educated in this, but we need to understand.
Especially when people are, literally some of them, they're taking literally, like, they've got trays of them. They're almost like a substitute for food. It's I don't know how they afford it, but nevertheless,
and stop because they don't know how they will feel. So it's really scary for them. They've received advice maybe from somebody who's asked them to take various supplements, and then it's really difficult to know when to stop.
Yeah. You also mentioned their oral estrogen. Now, we know in the past that the synthetic estrogen that was given such a bad rap in the WHI was that it has first pass in the liver and it can increase the risk of stroke and DVTs and things like that. But what do we know about the newer oral ones, and do they carry a similar sort of risk, or how are we unfairly demonizing oral estrogens anyway, because either one of those, a lot of women might do very well on?
Personal opinion is, it's definitely part of my regime. I have seen so many times the complications of separating the hormones up and people getting muddled or changing things themselves, and the balance of estrogen and progesterone just not being adequate for them. So that's something that an oral estrogen can, either an oral tablet alongside your Mirena coil, it can be easy for some people, or a combined oral tablet with estrogen plus progesterone can be easy too. And there is a small increased risk of blood clot. Usually this is greatest in the first 6 months of use, so you don't want to be on and off oral estrogen therapies, we wouldn't give it to somebody with high risk. So somebody it's really tricky because some people simply don't absorb through the skin. They've tried everything at maximum licensed doses. You could go up and up and they're still getting very little absorption. So you need to then do a really balanced risk benefit assessment about whether they're okay to take oral estrogen and whether it's safe for them to take it. And many people prefer that. So they want to have it as an option. Others prefer to take things through the skin. They find it easy. They don't want the increased risk of blood clot. So they prefer that. So you have to be just very safe with your prescribing, and also on an individualized basis, give it as an option for people who can safely take it.
Yeah. The other thing that is very, very interesting about all of this too is tests and levels. People are very, very focused on what their estrogen levels are. But I wanted to ask you something sort of slightly different in a way. So all right, so let's just break it down initially. So we've got people who would go through menopause naturally after the age of 45. Do they need to have their estrogen or any other levels tested before they start HRT, or at a regular basis going on if they do?
So no, the advice is that no, not unless we're considering, we're unsure about the diagnosis, or we're thinking there is another diagnosis. And often it's very easy in medicine to miss something by just blindly thinking one thing is only happening. So we might want to test, but the recommendation is that we don't test in the over 45s, and we also don't need to test estrogen levels. The only thing I'd be considering is if somebody is really is on a maximum licensed dose of product and they're still having ongoing symptoms, do we test estrogen levels, or do we just consider a different type of product? So and also look for other causes and look for lifestyle triggers. So you wouldn't necessarily be thinking it's helpful because there's no level to reach. So there's no blood level that you have to reach in order to say, okay, well, I'm good now. I'm fine. Everything's fine. My future health is protected. My symptoms are okay. Because women need different estrogen levels in order to feel well. And we know that we get bone protection even from a low dose estrogen product. So I think it can be very confusing for women, and levels can vary with the same product from sort of day to day. So sometimes it is worth testing on an individual basis, but as a general rule, it's not that helpful, and particularly not in perimenopause when you've got your own endogenous, your ovary estrogen, plus the estrogen you're adding in your hormone replacement therapy to produce this level. How do you know which is coming from your ovary and which is coming from the HRT? And you've also got estradiol in your serum, your blood, and you've got estrone, which is this thing we don't test. So there's this like two pools of estrogen, E1 and E2. They're sort of flowing between each other. So you can't just test E2 and then think, oh, well, this is okay, you know, or this is too low. I mean, you're not looking at the whole picture. So
that's really interesting. I don't think people realize that they think it's just this one block, and that there is this, you know, they interchange, they go backwards and forwards, which can really affect that result. And it's so important to understand that, isn't it? Because I don't think there's a lot of recognition of that at all.
No, there's not. And
same with testosterone.
Yeah, I mean, you could be testing you could be looking at your precursors, or you could be looking at your active testosterone. And also you've got to think about what they call intracrinology, don't they? So the actual in the cell, what's happening, and you can't test that. You're testing the blood, not what's happening in the cell. So there's a lot of things I think to consider, that we get very hung up on blood test levels. And for some people, you know, they strive to increase their dose of estrogen in hormone replacement therapy to reach a level, yet they are really unwell on that estrogen level, on that estrogen dose. It gives them horrible side effects, but they feel so much that they need to reach this level. They must go through these side effects in order to produce this level, which we don't know that there is a level to reach. So we'd want to make sure women who are young, people with POI, are definitely absorbing their estrogen. You know, and Turner syndrome is a little bit different. But if we're talking about women over the age of 45, then we're not looking to physiologically replace their natural ovarian cycle. We're looking to relieve their symptoms, and they will also potentially, depending on their medical conditions and age of starting, get benefit for reduced risk of cardiovascular disease and protection of bones. But it depends when they started and what their own medical history is, and how long ago their menopause was, as it were.
Yeah. So you mentioned their POI. So before I ask you about what tests you do to diagnose it, but is there then a difference in the testing that you would do for somebody who has POI or went through surgical menopause? Would you test them more often to make sure their levels are within a specific area or range, to make sure that they were getting the benefits? Or are we just assuming that if they're not symptomatic, that they're getting those benefits anyway?
I think that's really tricky to know, because sometimes people with POI don't have any symptoms, and you're giving them
once you've diagnosed them and you've decided and you put them on HRT, do you treat them differently afterwards in terms of measuring levels and stuff?
I might ensure that that patients with POI are absorbing, but I mean, they already are going to be going on to a higher dose of estrogen. So I look at them in an individual basis alongside their symptoms. I wouldn't naturally be testing, but I might test with somebody just to be sure that they're definitely absorbing the things that are going into their body.
So it wouldn't be then, you know, because the reason why I ask actually is because somebody was asking me, you know, they were saying, you know, my doctor won't, I've been through surgical menopause and they won't test my levels. And I was thinking to myself, do they actually necessarily need, once they've got you there, and if you're asymptomatic, do you need to be any more reviews really? Because this is something that's not talked about very much, actually, surgical menopause and POI and the management of it afterwards. It's just, so she seemed to be under the impression that, you know, she needed to be tested much more regularly than your annual review. But is that something that would or not necessarily?
I've not read that's in any guidance, and I would be looking at her symptoms and her dose and how she is. But regular testing is not in any guidance that I know of.
All right. Going back to then people from the ages of who might be going through menopause earlier, like between the 40 and 45 age group, what tests do we do for them? What do they need?
So I think this is such a brilliant thing, right? So this is such a topic that people always think menopause has got to be that 1 year after your final menstrual period. But that's the case for people who are 45 and above, of course. But people who are under 45, then there's a slight discrepancy in how many months it is, but let's talk 3 to 4 months of irregular periods, plus POI would be 1 level above 25 of FSH. Early menopause, 40 to 45, would be 2 levels of FSH, 4 to 6 weeks apart, plus irregular periods. So we'd be talking, we use the word oligomenorrhea, which to me means periods happening less often than every 35 days. So we should, once you reach puberty, you have your first period, you have 3 years or so to settle into a regular cycle. And you usually would settle into a cycle, a menstrual period happening between every 21 to 35 days. So if you are starting to, for 3 or 4 months, skip periods, have long gaps between your periods, we need to think, why is that happening? Don't ignore it, because it could be early menopause. You haven't had a year without a period, but you've had this infrequent, irregular periods suddenly. So I had a patient this week who I was looking at. She was in her early 40s. She had 27, 28 day bang on periods, and suddenly they become closer together and then really much further apart. Lots of symptoms. So we're obviously going to be looking at her for, she's already had 1 FSH level. Now we'll be looking at another FSH. It is this early menopause. So you'd also think of other reasons. So could they be pregnant? Has there been stress, excessive exercise, weight gain, weight loss? Other causes for changing periods, PMOS, can cause very infrequent periods. So we need to think period regularity is really important. So you look at the cycle regularity, you look, what's the cycle like? Is it heavy? Is it normal? Is it light? Is there a reason for heavy, painful periods? Is it irregular? Why is that? So the diagnostic criteria are very different, and obviously the BMS suggests that we should manage people with early menopause in a similar way to people with POI. So it's definitely not a diagnosis to miss, and something to be dealt with really carefully.
Yeah, absolutely. And with different ethnic groups, this is the other thing too, because certain ethnic groups go through menopause, a good three or so years earlier. So if they're turning up then, and let's say people from Southeast Asia or whatever, they'd normally go through menopause at around about 47 or so instead of 51. So if they could be having these symptoms in their late 30s. So do we have to think differently then about different ethnic groups and what they go through and when they go through it, and treat them accordingly? Just sort of like bring that down to the next level for the tests that we do.
We need to have everybody sort of as a sort of circle with everyone's different irregularities, as it were. We all have them for wherever we are. We need to know that people's symptoms can be different depending on where they are or what their genetic background is. And also we're looking specifically at BMI, those people, the risk of carrying weight around the middle, of being, we would classify weight categories different depending on where people come from in the world. So we need to take an approach that's really holistic, depending on the person's genetic background and ethnicity, because those will affect, different people have different symptoms, different prevalence of symptoms, for example. So more hot flushes, more vulval, vaginal symptoms, those sorts of things, more things which they may not tell you about, but you need to be aware that they could be more common in that group of people, and that actually you need to be asking outright about it.
Yeah. You also mentioned in there bone protection as well. And this is one of the things that is really important, obviously, around about menopause, because in that period of time, a couple of years before we go through menopause, and sorry, I've got a lot of noise going on, and it's normally really quiet here, but it seems to become a super highway. Yes, it's Friday afternoon. Everybody's going to the beach. Well, I lost my track of where I was going with that. Where was I going? Osteoporosis. That sort of couple of years before menopause and a couple of years after menopause, we can lose up to 20% of our bone. So there's the BMS is now saying that HRT should be considered as a treatment for that, with to prevent that with people going through menopause. Do you think there's enough awareness of that? Because we still find that it still seems to be sort of, oh no, we don't give it for that.
I don't think there's enough awareness about bones. I don't think people really understand the implications of having a fracture. So if we look at, 1 in 2 women over the age of 50 would have a fracture. So if I'm always talking about the 80-year-old us, we want to make sure she's got enough dietary calcium, vitamin D, she's doing the weight-bearing exercise. If we have a fracture and you fracture your hip, for example, we have that 30% chance of dying within the year. But fracturing even your left arm leaves you with difficulty potentially she driving? So there are lots of things we need to consider. What are the risk factors for this woman? We should be assessing risk factors, and I do that for pretty much everyone who comes to my clinic, just to think, where are her risks for her bone here? So has her parent fractured a hip? Is she a smoker? Does she drink alcohol? Has she got rheumatoid arthritis? Is she diabetic? Did she have untreated early menopause, thyroid disease? Those sorts of things. I'd have a low threshold to arrange a bone scan for somebody. And yeah, we need to consider this fast rate of bone loss at that time. And so that's why the benefits of starting hormone replacement therapy in perimenopause are now becoming really clear, aren't they, before we have that big loss of bone. Although when we stop HRT, the bone loss would essentially go back to what it would have been if we'd never taken HRT. But many people now are choosing to take HRT. Well, of course, we can take it for as long as we want, and many people are choosing to stay on the HRT for longer than that historical 5-year guidance that we were given, years ago.
You're saying that you need for bone protection, a 50 microgram patch is probably sufficient. But again, then do we need to test to make sure there's sufficient estrogen in the blood, or are we just thankful that the patch will be doing its job?
Yeah, and I think even there is a study to show that even a lower dose patch can give bone protection. So there is no guidance that we need to treat people in order to find a level of estradiol, remembering estradiol and estrone in the blood, that gives us bone protection. And no, I mean, sure that this area may change, of course, and we know that, globally, I think I'm struggling to remember the numbers of people, but there was something like 19% of people have got osteoporosis, and this could be wrong, but I'm going to say something about 40% have osteopenia. So a lot more people have got osteopenia. Therefore, the fracture rates in osteopenia group is higher because there's more of us. It's normal for that to happen. So we want to be managing the osteopenia, preventing the osteoporosis from developing, but looking so that people understand their risk to bone, because they don't really necessarily understand that bone's like this active live organ. It's continually remodeling itself. We want to make sure it's not remodeling and becoming very delicate, so that if you fall over, you fracture something super easily by just rolling over in bed and fracturing your part of your spine, because that then causes people to shrink, and it can cause an awful lot of pain. And osteoporosis, as we both know, is not painful until you fracture something, and then it's significantly a problem. So yeah, we want to be protecting bone. We can look at the FRAX score. We can also, there are other treatments which are effective but maybe not very well tolerated to help with bone health. So we need to be looking at hormonal treatments depending on your risk. Somebody's really high risk, right at the red box at the top, super high risk, I'd be asking advice from a bone specialist. I wouldn't sort of be thinking, is this the right treatment? And of course, HRT is not, it's not necessary. It's not licensed to treat osteoporosis. It's something that we need to consider.
Yeah. My final question for you, of course, is the other one that I love, and that is as we go through menopause and into postmenopause, those metabolic changes, cardiometabolic changes that we need to look out for. What are the main ones there that you talk about in the group that everybody should be aware of in the book?
So I think that checking your blood pressure annually, because that goes up as we age. Menopause may have an effect on that, but it goes up as we age. And also checking your blood lipids so that you know what they are. Then you have your Q risk 3 score. So you need to put your blood lipids and all your medical conditions for the questions into a little Q risk 3 score, and that gives you a risk of heart disease over the next 10 years. And then you could act on that. Do you need to treat your cholesterol or not? And you want to be making healthy lifestyle choices, and you also want to be looking really carefully at managing weight, because we know you okay? I can see lots of noises. Goes on more easily around the waist, so we might find visceral fat increasing, which increases our risk of inflammation and cardiovascular disease. So there's a lot of things for us to look at in the middle of our lives.
There absolutely are. So brilliant. On that note, I'm going to have to wrap this up because I have to take my husband to the airport. So I will say an amazing congratulations once more on the production of this fantastic book with two other amazing women, Angela Wright and Angela Sharma, who I shall also drag on to discuss their sections. And if people want to find this, where do they find it?
So they can go onto the Scion website, so SCION, and then you can use the code SCION35 to get a 35% discount, or it's available on Amazon.
Excellent. Very, very good. So look, thank you again for that. And I will be speaking to you in the not too distant future, I hope. And,
Yeah.
and congratulations again.
Okay, take care.
You
Nice.
too.
Bye.